Hi, my name is Peter Keast. I'm a family nurse practitioner student at the University of Connecticut. The year is 2025. We're doing our final summative osteo examination. This is Jennifer, our volunteer. Jen, is it okay if we examine you today?
It is.
Okay. We're going to note Jen's medical record. We're going to don our PPE. We're going to assume good hand hygiene, and we'll note her vital signs before we begin our examination today. Jen, we're going to start with examining your skin. Can I see your arms and fingers? Turn over. Thank you. Adjust. Thank you. Tummy. Oh, legs are fine.
Oh, sorry.
No, it's fine. It's fine. It's fine. It's fine. Okay, thank you. Cover stomach. Thank you. Cover. Okay. Jen is a Catholic descent, 43-year-old female person. She is Caucasian. Her skin is warm to the touch in all four extremities. It has good turgor. There is no rashes, no erythema, no jaundice, no signs of central or peripheral cyanosis, no clipping of the fingernails, good capillary refill time, no interdigital rash, and we are going to continue with our examination. You can look at your hands. Thank you. Hair is full, thick, and well apportioned. No nits, no dandruff, no crusting lesions, no rashes, no skin signs on the scalp at all. Okay. Jen's face is symmetrical. Her head is atraumatic and normal cephalic. Just going to feel gently. Anything hurt? There's no depressions or injurious patterns. Jen's face is symmetrical. There's no lid line noted. All features are perfect. I'm just going to have you smile at me. Stick your tongue out. Move it left and right. Blow your cheeks up with air. Hold it. Good. Scrunch your eyes closed. Don't let me open it. Good. Can you, to the best of your ability, move your jaw left and right? That's fine. Thank you. So we're just doing our examinations of some of our cranial nerves. So we've actually just tested the hypoglossal cranial nerves, which is currently intact. We're going to continue with our examination, Jen. Feeling the TMJ, no swelling or tenderness, gentle open and close, smooth. We're going to examine the neck. Trachea is midline. The trachea is always midline. We're going to examine. There's no scars, there's no rash, there's no evidence of surgeries. We palpate from behind, palpating our thyroid gland. Okay, thank you very much. Swallow for me. Okay. Jen has a good swallow. Cranial nerves 9 and 10 are intact. The thyroid is not nodular, there's no goiter. If there was enlargement, we could do an auscultation looking for a thyroid bruit. For completeness, we will just we'll evaluate your carotid arteries now. +2, +2. Normal upstroke, no thrills. No thrills or worries noted. Just feel under your chin. Submental lymph nodes not present. Submandibular, tonsillar, preauricular, postauricular, posterior chain, occipital, deep cervical chain, not palpated, anterior cervical chain. There's no lymphadenopathy on examination. I'm going to just pull this down slightly. Supraclavicular lymphadenopathy, checking for viscerous node, not present. Infraclavicular lymphadenopathy, leading to the axilla. That's not present. Jen, to the best of your abilities, please turn your neck to the left, to the right, and come forward. Chin down towards your chest, and then back upwards. Is your neck feeling stiff at all? No. Okay, no nuchal rigidity. Neck has good full range of motion. Just turn against my hand gently. Very good. And I'll have you shrug your shoulders. Very good. Cranial nerve 11 is intact. The spinal accessory muscle is intact. We're going to move on to our next exam. I'm just going to do your ears, just have you close your eyes. Tell me if you hear a hum.
Yep. Yep.
Tell me if you hear the hum as I put this on your forehead on one side or both.
Both.
No lateralization. Wiper's negative. Do you hear the
Yep.
vibration? Tell me when it stops.
Yep. Yeah, I hear. Yep, stopped. Yeah, I hear.
Okay. She has generally appreciable hearing. Cranial nerve 8 is intact. We're going to look at the external auditory apparatus. Auricles, palpating the tragus and the mastoids, non-tender. We're going to have a look in your ear. Endoscopic examination. Be very careful. Thank you. Thank you. Tympanic membranes are intact. No erythema, no exudate, no polyps. We could use a pressure-based tympanometer. We don't have that here, so we're not going to be using that today. The auditory canal is free from cerumen. The handle of the malleus is visible on the eardrum. As I said, the eardrum is intact, it's pearlescent, it has a good color. The cone of light is visible on the right at 5 o'clock, the left at 7 o'clock, and there's no other abnormalities found. Jen, I'm just going to look at your nose. Does it hurt?
Nope.
Palpating our sinuses. Nose is symmetrical, no septal deviation, no rhinitis, no external changes to the skin. Just close your eyes for a second, Jen. Put one finger over one nostril on the ipsilateral side. I'm just going to say, can you smell this?
Got it.
Very good. We're going to the opposite side.
7.
Good. Cranial nerve 1 is intact. Look at your nostril. Thank you. Okay. Nerves are present throughout. The turbinates are visible. Soft, pink, moist, no polyps, no exudates, no masses, no abnormal findings within the nerves. We're just going to have a look in your mouth. I'm going to go on close. Open wide, say ah. Good, lift your tongue. Thank you. Thank you. Okay, I'm just going to move your tongue gently to the side. Checking our sublingual and buccal surfaces. Do your teeth hurt? Okay. Assessing the palate. Okay, one more time. Thank you very much. Posterior pharynx is clear. It's soft, it's pink, it's non-erythematous. There's no pus, there's no plaques, there's no leukoplakia on the tongue, there's no furring of the tongue, there's no fissuring of the tongue. The papillae are moist and they are appropriate for the tongue. It's of a normal diameter. She doesn't have a tongue tie. The sublingual and buccal surfaces are all free from any skin changes. The gingiva have no evidence of gingivitis, nor is there gingival hyperplasia. The teeth are all present. There's no caries, there's no decay, and there's no tenderness. The hard palate is tall and anterior, which is consistent with Jen's medical history. The uvula moves in symmetry and in centrally, and thus the hypoglossal nerve is still intact. We have a good swallow. The next thing we're going to do, Jen, is we're going to check out your eyes. First thing I'm going to ask you to do is put on your glasses, cover your right eye, cover your right eye. Tell them 15 inches, how far, the smallest line you can read.
LTFPH. LTFPH. LTFPH.
Okay, 20/20 left and right, corrected and symmetrical. Oh, What color is that?
Red,
That?
green.
No color loss. Can you see my fingers?
No, sorry. Yes, good. Yes,
Good. What is this object?
it's a pen light.
Good. Good. I'd like you to look at my nose. Actually, could you take your glasses off? Look at this object now. We're going to check our range of motion, so just going to check our cranial nerves. 6 abducens left and right. Okay, so this is 4 left, 3 right. This is 4 right, 3 left. 3 left and right. 3 left and right. Good. I'm just going to keep looking at my nose. Thank you. Thank you. Look at this object as it approaches you. Keep your head still. It won't touch you. Okay. Jen's pupils are equal, round, and reactive to light. 4 constricting down to 2. The irises are blue. The lens is clear. There's no signs of corneal arcus. There is equal accommodation and reactivity of the lenses. There are no lid lag. There is no nystagmus. There are no negative extraocular movements of note. Her field of vision and range of vision is within normal range. In just a second, we'll perform our fundoscopy. We're just going to evaluate the anterior chamber. Look at my nose. Thank you. Thank you. Based on the transillumination, there's no evidence of raised intraocular pressure. Just going to look at your eyes, look at me. Evaluating the cornea and the sclera. The lacrimal apparatus is appreciated. There's no tearing. The cornea and sclera are fundamentally clear without inflammation, mass, or tenderness. There's no skin changes around the eyes. We're now going to do our fundoscopy exam. And I'm going to have you look behind me. I'm going to turn down the lights. Look at the wall behind me. 15 into 15. Look at me. Good. Look at me. Good. Fundoscopic exam is normal. She has a bright red reflex left and right. The optic disc is not dilated nor flattened. There's no evidence of papilledema. The disc to cup ratio is 1 to 2. The fovea and macula are dark brown, reddy brown color. There are no exudates, hemorrhages, or abnormal findings within the eye. There's no hypertensive retinopathy. Arteries and veins are well distinguished, veins being flatter and straighter, arteries being more tortuous. The retina is intact. This completes our fundoscopic examination of the eye. Okay, Jen, we're going to do our respiratory exam at this time, if that's all right. I'm just going to have you face in that direction to start. So as we've been talking to Jen, there's no accessory muscle movement, there's no respiratory distress. We've evaluated for peripheral and central cyanosis, and we know that Jen's not using currently any accessory muscles. There's no intercostal retractions noted. Jen, I'm just going to inspect your anterior chest for heaves or chills. Take a few deep breaths. That's great. That's absolutely fine. I'm going to palpate your chest, Jen. Just let me know if I hurt you. Okay, thank you. Cover. Palpate the posterior chest. So we didn't check before. We didn't check our neck muscles. So is this tender?
No.
Okay. Gentle palpation on the posterior chest. Does that hurt?
No.
Great. Say 99.
99. 99. 99. 99.
Thank you very much. We're now going to percuss in the posterior fields. We're going to move laterally and then anteriorly in our ladder pattern. Tympanic. Cardiac dullness is noted at the left fifth clavicular line. We're now going to auscultate, okay? Jen, I'm just going to listen in posteriorly first with the diaphragm. We can cover at the front slightly. Deep, if you lean forward, deep breaths in and out through your mouth and relax. ladder pattern. Lateral. Good. Vesicular throughout. And then listen to the anterior fields. Follow. Lateral. Good. Good. You can cover, and we're going to face this way. Vesicular breath sounds throughout. No extra sounds, no wheeze, no rails, no crackles, no bronchophony. There's nothing wildly untoward. We're now going to do our bronchophony, agophony, and whispered soliloquy, if that's okay. So stay as you are. I just want you to say, we did our premises check. I just want you to say 99 when I touch you with the stethoscope.
99, 99, 99, 99, 99, 99.
Very good. Again.
99, 99.
Thank you very much. I want you to say the letter E and hold it.
E.
Okay, thank you. Now I just want you to whisper. Pss, 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 pss. Okay, that's not heard. Thank you very much. No bronchophony, no agophony, no whispered soliloquy is noted at this time. Jen, we're going to move to our cardiac exam, so I'm going to have you lay back. We're going to have you lay at 30 degrees to the best of our ability against that pillow. Just pull down the part of your drape there. We're going to use transillumination on the right side to evaluate for a JVP wave. Carotid pulsations are noted. JVP is not appreciated. If the JVP was appreciated, what we could do is, from this 30-degree position, we could check from the sternal-manubrial angle at 90 degrees and then compare it to the height of the right atrium to get a number for the central venous pressure. Observing the chest, there's no thrills or heaves, paradoxical movements. No abnormal pulsations are felt. I'm going to palpate the anterior chest, just gently touching. So now we're at the right second interspace, no aortic pulsations. Left second, no pulmonic. Left fourth and fifth, for any right ventricular heaves, they're not appreciated. In the mid-clavicular line, fifth intercostal space, there's a 2 centimeter pulse, point of maximum mid-pulse. It has a gentle tapping reference against the hand, indicating that it's normal. There's no evidence of cardiomegaly, so we're not actually going to percuss out the cardiac borders. Can I have you sit forward, Jen, just a little bit while I listen? Okay, thank you. Listening to our heart sounds. Lexit. We're going to start with the diaphragm. Left side. Left fourth and fifth. Okay, that's going to be the... Okay, now lean forward slightly more. I'm going to listen with the bell. Thank you. Okay, now lay down on your left side, laying flat. Now I'm going to check for mitral stenosis murmur using the diaphragm and then the bell in the left lateral recumbent position. Okay, thank you. There's a proud S1 and S2. There's no splitting, rubs, murmurs. If there was such a murmur, we would quantify and qualify it based on the timing of the cardiac cycle, the duration, intensity, and pitch. What we're going to do now, Jen, move on to our peripheral vascular examination. Noting the lower extremities, they're warm to the touch. There is no edema. If there was pitting edema, we could measure it. We're going to put on one glove. We'll check our neurovascular state. Actually, we're just going to be above. Dorsalis pedis is felt, +2 on both sides. Posterior tibialis. Popliteal. And we'll do femoral and inguinal just on the next exam. A few superficial varicosities. You can actually cover yourself. We're going to just look at the upper extremities now. Feeling our anatomy. So, radial pulses are evaluated. Capillary refill time on the feet was less than 3 seconds. Ulnar. Capillary refill time of these fingers is less than 3 seconds. Brachioradialis. Brachioradialis. We've already assessed our carotid arteries. There's no edema, they're fundamentally symmetrical, and no abnormalities within the peripheral vascular exam at this time. What we're going to do next, Jen, is our abdominal examination. So I'd like you to lay back and lay flat. If you can move that pillow.
Can I just do this?
Yep, that's fine.
Actually, no, I can't do that. Yeah.
Thank you. The abdomen is rounded but fundamentally flat and in linear alignment. There's no abnormal pulsations, there's no masses visible, there's no herniation, the umbilicus is appropriate, skin's intact. We noticed a few freckles before and a few hemangiomas. Just going to have a quick listen, all 4 quadrants. Bowel sounds are normal active. You're going to listen for the aorta, and the renal arteries. Those sounds are not appreciated. The aorta is not palpable on the anterior chest or anterior abdomen. And we didn't hear the aortic pulsation, so there's no heaves or thrills to note, and the renal arteries are silent. We can't hear those. What we're going to do now is percuss out our liver edge, right midclavicular line at the umbilicus. Okay, we hit dullness at about the 8th interspace on the right side. Just going to go down from the top, and I'll just go over the top of your clothes. It's okay. Okay, and the 4th midclavicular line, the 3rd actually on the right side, giving us a top to bottom reference of about 5 centimeters, which is physiologically normal at this time. We're going to check for splenomegaly just by tapping on the sides here. Okay, there's tympany throughout. There's no dullness noted. We're now going to just check for any evidence of shifting dullness by tympany is noted throughout. No shifting dullness. We don't need to do a wave test. There's no clinical ascites. I'm going to palpate gently, looking for masses, abnormal pulsations, lymph nodes. If there were any masses, we characterize them by their shape, size, and movement. Light palpation first, right, left, right lower quadrant, right upper. Does this hurt?
No.
Left upper, left lower. Okay, we're now going to move on to deep palpation. Right lower quadrant, does that hurt?
No.
Okay, right upper quadrant, does that hurt?
No.
Very good. Cough for me, we're just going to do a cough sign. Okay, negative appendiceal sign at this time. Take a deep breath in and breathe out. Okay, Murphy's is negative, clinically no evidence of cholecystitis. The liver edge is not appreciable as deep inspiration occurs. We don't feel it fall beneath the rib line. Left upper quadrant, deep palpation. Left lower, any pain, Jen?
No.
I'm going to press deeply and release. No peritonism, no rebound tenderness. Rosvig sign is inherently negative. Just going to pull this down slightly. I'm going to palpate for those superficial inguinal lymph nodes. They are not present. Vertical or horizontal chains. Just going to palpate our femoral pulses. They are present. They are +2. Please excuse. Okay, we're going to continue with our appendiceal signs. We're Rosvig negative, we're cough negative. Keep it covered. What I'd like you to do is just to lift your, this can be down, and this one can be down to start, and just lift against resistance. Does that hurt you? Lovely. I'll take the leg now. So psoas sign is negative. We're now going to do the obturator internus sign, and you're just going to guide me. And the obturator internus sign is negative. Thank you very much. You can put that back down. And the one thing that we've forgotten before, Jen, if you can sit up for me and just face this direction. Assessment for cross-vertebral artery tenderness. I'm just going to give you a little bap on the back, okay? Gentle percussion on the bottom. Does that hurt you at all? No evidence of pyelonephritis. You look at me, we're going to do our musculoskeletal exam. We're going to start with our lower extremities, moving distally to proximal. Okay. We're noting our feet, distal interphalangeal joints, proximal interphalangeal joints, the metatarsophalangeal joints, the metatarsal bones are noted. The anterior aspect of the tibial insertion is noted. We have a medial and lateral malleolus. The Achilles tendon is appreciable. The calcaneus is appreciable. And we can feel the plantar fascia. There's no edema. And I'm sure it'll be the exact same on this side. Medial and lateral, steps, tibia, toes. Thank you very much. We're going to examine briefly the knee. We're going to palpate the medial collateral ligament, the lateral collateral ligament, the meniscus, medial meniscus, the lateral meniscus, the suprapatellar bursa, the infrapatellar bursa, and the subpatellar bursa. Subpatellar, patellar, or subpatellar bursa, sorry. This is infrapatellar bursa, this is subpatellar bursa, and this is suprapatellar bursa. With our medial and collateral and our menisci. We're not going to do external rotation, valgus and varus movements with the knee. It's going to hurt, Jen. We're not going to do that. Can I have you sit back for me for just a moment? We're going to do active range of motion. So I'd like you to lift in a laying down or reverse position. We're going to have you bring your thigh up. We're going to have you fully extend and then reverse the opposite leg. So we have full flexion and extension and active range of motion. We're going to do our strength rating since we have the opportunity. Just up against my hands, 5 out of 5 in flexion and extension. Now I'd like you to press your knees out and bring them in. Abduction and adduction is 5 out of 5. Extension of the knee and flexion of the knee is 5 out of 5. 5 out of 5. Now we're going to do plantar and dorsiflexion of the foot. Down, up, toes down, up. Good. Other one. Down, up, toes down, up. Very good. So within the lower extremities, all power is 5 out of 5. We're now going to do a squeeze test. Grab my fingers with your hands. Like grab onto them like they are. Sorry about that. There. Grab onto my fingers. Good, strong grip strength, 5 out of 5. Thumbs like this. Don't let me push. Don't let me pull. Good. Wrist like this. Don't let me push. Don't let me pull. So we actually tested the wrists and the biceps in that, 5 out of 5 throughout. Arms out like this, to the best of your abilities. Don't let me. Very good. Now, upper extremity strength, flexion, and extension of the elbows is 5 out of 5. I'd like you to extend your fingers. Don't let me squish them. Excellent. 5 out of 5 throughout. That's what we're going to do now. As we're doing this, we've done our shoulders, we've done our upper musculoskeletal. We're going to check our deep tendon reflexes to wrap this up. Just for a second. Thank you. Brisk. 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 Good. Good. Biceps and triceps deep tendon reflexes are normal. We're going to do the patellar tendons and just relax to the best of your ability. Good. Good. Going to do the Achilles. Good. Good. We're going to do the Babinski. Now going. Down going. Deep tendon reflexes are all examined throughout. I'm going to stand up. I'll have you approach me first. There we go. Just going to examine Jen's physiology. Greater throat cancer, trochanteric bursa, iliac crest, superior iliac spine anterior. Turn around for me, no tenderness. Okay. Iliac crest, posterior superior iliac spine, and the SI joints, tender. We're looking for muscle wasting, atrophy, asymmetry. Jen, if you could just walk a few steps straight ahead to normal, okay? Walk back to the best of your ability, heel to toe. Okay, just the best of your
That's
ability.
just embarrassing.
And a few on your tiptoes, a few on your heels. That's fine. Stay still, looking toward the camera. Joint position sense is good. Hold your arms out like this. Supinate. Close your eyes. I'm going to tap your hands. No pronate or drift. Relax your arms down at your sides. Keep your eyes closed. 30 seconds Romberg's is negative. Something we didn't do before, but we should. We're going to do tone and range of motion for these arms, just equally with me, like we're dancing. Okay, and a few movements that we haven't done yet. So we have done our thumbs. I'd like you to bring your elbows in like this, and we're going to do radial and ulnar deviation of the wrists. We're going to bring this out. Good. And this is internal. This is actually external rotation of the shoulder. And put ours behind our back. Internal rotation of the shoulder. We've done pronation and supination, and we've done our leg movements as well. The next thing I'd like you to do before you sit is see if you can give me just a shallow knee bend. Thank you very much. You can have a seat. We're going to do a few quick rapid movements, and then we'll finish your neurological examination, and we'll be complete today. With your hands on your knees, do this. Good. Now that's no dysbiokinesia, so same thing, tippy tappies with your feet. So rapid alteration, that's normal. With the right heel, I want you to scratch the inside of your left leg. Reverse it. Excellent. With your right index finger, touch your nose. My finger, nose. Left index finger, the same. Just by way of explanation, all of our cranial nerves have actually been tested and processed, and they are currently intact. There's no past pointing defects, there's no dysbiokinesia. We're just going to finish the neurological findings and move on. So Jen, I just want you to close your eyes for a second. Tell me where I am touching you with this on your body.
Right forearm, left upper arm, right cheek, left lower leg, right lower leg.
Okay. Now we're going to do discrimination sense. So this is feeling sharp. This is dull. What is this?
Sharp,
What is this?
dull,
What is this?
sharp,
What is this?
dull.
What is this?
Sharp,
What is this?
dull, dull.
Very good. Just keep your eyes closed. Do you feel this vibrating?
Yes.
Tell me when it stops.
Yep, stop.
Same again.
Stop. Stop. Stop.
Very good. You can open your eyes and relax. Testing our hot and cold. Or wet and dry. I think more appropriate. So this is cold for sure. This is hot. Close your eyes.
Cold. Hot?
Yep.
Cold. Cold.
Good.
Cold. Oh,
It's okay. That's right.
hot.
Good. Open and show me your hands. Keep your eyes closed. I'm going to put something in your hand. I want you to tell me what the object is.
The egg, percussion egg.
Very good. I'm now going to write a number in your hand. I want you to tell me what number I write.
4. 8.
Very good. You can open your eyes. I'm going to have you close your eyes, actually realizing that I'm just going to check to see if you can discriminate between 2 and 1 point. Okay. How many points are touching you?
2. 2. 1, 2, 1,
Good.
2, 1, 2.
Good. Okay. So there's no graphesthesia, stereognosis, or any other such abnormal neurological findings. We're just going to describe Jen. Her language, in terms of Jen's speech, is fluent. It's articulate. It's clear. Jen's a good historian. Jen, do you know what your date of birth is?
1/26/82.
Great. Where are we now?
We're in my house in Middletown.
What's the occasion for meeting?
Right now,
Yeah.
head-to-toe examination.
Good. Who's the current president?
Trump.
We're going to say 3 animal types, then we're going to say dog, cat, and giraffe. I want you to remember those for later. Can you please add serial 7s up to 21?
7, 14, 21.
Can you multiply 3 times 3 until you get to 33?
3, 6, 9, 12, 15, 18, 21, 24, 27, 30.
Perfect. Yeah, no, that's absolutely right. Can you spell the word world backwards?
Oh god. DLROW.
Very good. What is the name of a distant relative in Ireland?
Great Auntie Maya.
Okay. Any mood alterations today, Jen? Depression or anxiety? Are you hearing or seeing anything that may not be there for me to hear or see?
No.
Any fixed ideas about yourself or others?
No.
Okay. Do you feel particularly anxious or depressed?
No.
Okay. In terms of Jen's affect, her affect is normal. Her mood is currently euthymic. She's neither elevated nor low. There's no evidence of mania. There's no evidence of severe or crippling depression. She's not having hallucinations nor delusions. Her short-term memory is intact. What are the 3 animals that I asked you to remember?
Dog, cat, giraffe.
Her short-term and long-term recall are good. Can you tell me what the saying, you can't teach an old dog new tricks?
I mean, someone who's older is harder to learn new information.
You're gosh darn right. That is really, really hard. And in terms of our neurological testing, we are all set. Just having a quick think to wrap up before we end today. Our cranial nerve examinations are complete. Thank you. Have a good day.
30